I am Dr. Di Maria. I am an interventional cardiologist. I work at the John Radcliffe Hospital, Oxford University, NHS Foundation Trust in Oxford, UK. Thanks for the invitation and for sharing with you an update and results of the PICSO-AMI-I clinical trial, assessing the application of PiCSO therapy in patients with anterior ST elevation myocardial infarction. We need to say that our treatment in patients with ST elevation myocardial infarction is dramatically improved over the last few decades. As a matter of fact, in 2023, we can actually celebrate the 30th birthday of the first clinical trial, the PIMI clinical trial that demonstrated the benefit of primary PCI over thrombolysis in patients with STEMI. But the reality is that 30 years down the line, we are now in a position where we have definitely improved the way we can treat these patients, but our performance is kind of plateaued, and we are now at a point where actually we are not managing to improve even further the clinical outcome despite reducing, for example, pre-procedural ischemic time. So, and we know that still today, a variable proportion that can go between 20-25% roughly, according to national or international registries, we know that 20-25% of patients might still develop heart failure sooner or later after presentation with ST elevation myocardial infarction, which is the reason why there is a potential still unmet clinical need in this regard. The PiCSO therapy is an evolution, is a percutaneous evolution of a pretty old concept about reperfusing the heart, let's say, from the back door, from the coronary sinus, which, as we know, is the main venous drain system of the heart. Already back in the 40s, actually, it was demonstrated that it was possible to reperfuse the heart in a retrograde manner, indeed. That was even before the coronary artery bypass grafting era. And then, of course, with the PiCSO therapy now, this concept now has become potentially suitable in a percutaneous manner. So the PiCSO therapy in itself consists of a PiCSO Impulse catheter, which is a balloon-tipped catheter that is inserted in the coronary sinus via a femoral venous access. And the second component of the system is a dedicated console, so the PiCSO Impulse console, which, in other words, by looking at the ECG and variation of pressure within the coronary sinus, applies a proprietary algorithm that regulate the inflation and deflation cycles of the balloon once it is in place in the coronary sinus. In other words, what the PiCSO therapy does, we have a balloon that is placed in the coronary sinus, and the balloon inflates in the coronary sinus. It stays inflated for a few cardiac cycles, and then it does deflate. So during the inflation phase, what happens, there is an increase in venous pressure that is anticipated to redistribute myocardial blood flow from the non-ischemic myocardium to the ischemic myocardium. And it is exactly the mechanism advocated by which the therapy could reduce, for example, infarct size or improve myocardial reperfusion. And on the other end, when the balloon does deflate, of course, the normal venous drainage of the heart is guaranteed. So there is little risk in terms of myocardial engorgement or risk of intramyocardial hemorrhage, because, again, this is not a permanent device. It's a device that during the deflation of the balloon allows for the normal venous drainage to take place. So the study was the result of previous, of course, investigations. So starting from data available from the animal model and from preliminary non-randomized proof of concept study that showed a possible effect in terms of infarct size reduction associated with the therapy. The PiCSO-AMI-I clinical trial was designed as an international multi-center parallel group 1-to-1 randomized clinical trial. Patients were randomized 1-to-1 to PiCSO-assisted primary PCI or conventional primary PCI. The main inclusion criteria looked at patients presenting with an anterior ST elevation myocardial infarction according to electrocardiographic criteria, and done with documentation of an occluded left anterior descending artery, specifically a TIMI 0-1 flow at the time of the invasive angiogram. And another point to remember, patients with an ischemic time less than 12 hours were eligible for the study. The primary endpoint of the study was to look at a reduction in infarct size at 5 days cardiac MRI scan. And the study was powered to show a 25% reduction in infarct size, assuming a 26% infarct size in the control group. And in this regard, an overall sample size of 144 patients was calculated to account for a power of 80%, an alpha error of 0.05, and assuming a 20% drop off rate at follow-up. And the study was conducted over roughly 3 years period. Of course, there was a hold during the COVID-19 pandemic, and the study involved 16 centers, tertiary centers across Europe. The first point to highlight is that it was proven that PiCSO therapy was feasible in patients presenting with a primary PCI, with an anterior STEMI going for primary PCI. And it was also proven that the addition of PiCSO therapy did not associate with increase in adverse events at 6-month follow-up, nor there was an increased rate of device-specific adverse events like vascular access complication or coronary sinus injury, for example. However, the PiCSO therapy, of course, represented an increase in terms of procedural time. By protocol, the operator was asked to provide at least 45 minutes, if possible, of PiCSO therapy. So as a consequence, what we did observe is that in the active group, procedural time, contrast dye, volume, and radiation exposure expectedly were, of course, significantly higher than in the controlled group. So when it comes to the primary endpoint of the study, so difference in infarct size at 5 days cardiac MRI scan, unfortunately, we could not observe, as initially pointed in the preliminary non-randomized clinical trial, a reduction in infarct size in the active group. So the infarct size at 5 days was comparable between the PiCSO-assisted primary PCI group and the control group. And this was true in the intention to treat analysis as well as in the per protocol analysis. On top of that, also we looked at possible subgroup analysis, and the absence of reduction in infarct size was pretty much consistent across the various subgroups that were eventually included and analyzed. It was not the primary endpoint of the study, but we looked also variation in infarct size at 6 months. This was not available in the whole cohort of patients enrolled. But also at 6 months, we could not detect a significant variation in infarct size between the active group and the control group. And equally, there was no difference between the PiCSO-assisted primary PCI group and the control group in terms of microvascular obstruction and intramyocardial hemorrhage at 5 days cardiac MRI scan. So at the moment, of course, the main result of the study is that we have on one end the therapy that, of course, is felt to be feasible, is felt to be safe, but of course it could not show the anticipated benefit that was initially, let's say, at least advocated by the non-randomized study that represented the preliminary work leading eventually to the PICSO-AMI-I clinical trial. Of course, the next step at the moment will be to have a clear understanding about whether the therapy could potentially be viable in specific, let's say, settings, and I'll explain myself. One of the possible explanation is that the inclusion criteria that we consider in the study, so just looking, for example, at TIMI 0-1 flow at presentation, could have been not enough to select that subgroup of patients with truly high chance of experiencing a large infarct, and that could eventually potentially benefit from an additional procedure. From preliminary work, we know indeed already that primary PCI works pretty well in the vast majority of patients. And then there is the idea that we should probably have a tool on top of TIMI 01 that can help us to identify truly high-risk patients that are anticipated to not respond well to the conventional treatment with primary PCI, and then targeted them specifically with an additional therapy like PiCSO, for example. In this regard, one of the preliminary studies that was conducted on this therapy, the PICSO-AMI-I that was performed here in Oxford, we did look at index of microvascular resistance, so IMR, measured before the procedure, so measured before the implant of the stent, as a possible criterion to establish whether there was a scope to provide additional treatment with PiCSO or not. So this approach was not, let's say, adopted in the study. And of course, a possible open question would be whether a new study using more, let's say, specific or ad hoc inclusion criteria beyond just TIMI zero flow could eventually help to have a clearer understanding whether this therapy still has a scope in patients with anterior elevation myocardial infarction or not.